everyone, and welcome back to Feed the Pod Plus. Today, we are diving into an area that's critical for any physiotherapist working with youth athletes. Injuries in immature football players with a spotlight on growth-related injuries. It's a topic that combines biomechanics, long-term development, and some tricky clinical decision-making. I'm really excited to be joined by Dr. Olivier Materne, a sports physiotherapist whose clinical and academic insights into youth injury patterns are incredibly valuable. We'll talk about risk factors, red flags, rehab dilemmas, and the often overlooked nuances of managing immature athletes. Whether you are in the clinic, on the field, or mentoring young physios, I think this conversation will leave you with both new perspectives and practical takeaways. So grab your coffee and let's get into it. And Dr. Materne, welcome. I know how impressive your clinical background is, but for our listeners, could you tell us a little bit about yourself?
So I'm a sports physiotherapist, working in the football now since around 25 years, 26 years. I start my career as a professional physiotherapist in the late 90s. And I start my career as a physical coach. And as I have the two backgrounds as a sports scientist and sport physiotherapist, a couple of years after the start, I really moved to focus on the sport physiotherapy and mainly with a focus on the youth athlete and the youth football players, because in early 2000, I just realized that the knowledge about the sport medicine and the specific needs of the young footballer wasn't there. And at that time, we were dealing with a young footballer like we are dealing with an adult. And I've decided to try to progress and to improve in this field. So this means from the early 2000, I really focus over 15, 20 years on the youth football player and try to develop a little bit the clinical skill, the clinical reasoning, and try to find a balance between the science and the clinical practice in the field and the youth development. But dealing with all specificities of the immature skeleton. And beside of that, regarding my academic background, so I got a diploma in sport physiotherapy and sport science, and as well one master on each side, and I did my PhD on pediatrics and growth and maturation injuries.
It's such an academic and supports with your careers, and we are so lucky because we are hosting you. And Dr. Matan, before we get started, I would like to ask you a more personal question, please. When we first reached out, you didn't know us at all. Yet you still agreed to take part in this podcast project, and we are truly grateful for that, obvious. But I can help but wonder, what made you say yes and support us? And more broadly, what's your perspective on professional podcasts like this one? I'm asking because podcasting has really become a rising trend around the world and nowadays.
Yeah, I think a podcast is an interesting tool to touch certain type of professional population. I think I can see with my team of physiotherapists, I can see also based on the age, people do not try to develop or get have different way to develop themselves or to get update about the science. I think the young generation of physiotherapists, I have few with me, they like podcast. Maybe people more older like me, we are maybe more on scientific papers.
Yeah.
But podcasts also with my young team, I start also to become a fan of podcasts because you can do other activity while listening and watching the podcast. So I think it's an interesting way to pass some knowledge and to discuss some relevant topic in a nice way. And so that's why I was happy to participate and to accept your invitation.
Oh, it's amazing. And thank you again. Okay, let's start then. Let's start with the basics because they are often go overlooked in clinical settings. Could you briefly explain what a growth plate is and why it's such a key concern in sports physiotherapy for young athletes?
So the growth plate, it's an area of cartilage to let often located at the extremities of the long bone, and often located at the extremities of the long bone and involved in the growth of the body. For the epiphyseal, metaphyseal, and physeal complex, and for the apophyseal, more or less involved on the size of the apophysis for the muscle attachment by the tendon. So the epiphyseal, physeal, metaphyseal complex are, let's say, involved in growth, and while the apophyseal area are not at all involved in growth, but more on the size. And doesn't matter the type of growth cartilage. They are mainly the cartilage, mainly organized in 4 different zones. And to go through the fusion, the ossification, maturation process, these zones must go through what we call the endochondral maturation, and this is usually, let's say, the weakest moment regarding injuries when this the growth cartilage go through this endochondral ossification process. And of course, the endochondral ossification process doesn't occur in the same time at every different growth plate spot or area. There is a chronology, is dependent to every player, every athlete, but the sequence keep almost always the same chronology of ossification process. We shall can talk maybe a little bit later. Yeah, this is, let's say, in general, what is the growth plate.
Okay, thank you. I think a lot of us in the clinic sometimes underestimate how active the growth plate still is, especially in those later peripubertal years. And it's not just about pain, right? It's about potential disruption to long-term development if not handled bad. And that's bring us perfectly to the next point. Why exactly are these younger players more at risk? So what I want to ask is this: from your perspective, what makes immature youth football players more biomechanically or physiologically prone to injury compared to post-pubertal athletes?
So most of the endochondral ossification in the growth plate occur before the peak high velocity and during the peak high velocity. Still, some bone or some apophysis occur after. But what is very important to understand is a different type of growth plate injuries we can have, because based on the type of growth plate injuries, the outcome will not be the same in terms of management, treatment, time frame, and also the risk. The risk of this type of injury is not the same as well. There is, for me, and not for me, but in the literature, I think we can summarize that we have 3 important type of growth plate injuries. We have, let's say, the acute onset physial fracture, which correspond to the salteraris type of fracture. This is one type of fracture need to be managed in a certain way. Then we have what we call the primary periphyseal stress injuries, which is touch mostly the epiphyseal, physeal, and metaphyseal complex, but due to repetitive stress, usually this type of fracture are underestimated in under-diagnosed, but as well underestimated in the literature. If my memory is good, I think there is only around 120, 130 papers over the last 75 years. So it's still a kind of type of injuries, distress, gross plate fracture injuries, underestimate and not enough well recognized in sport. And the athlete, the young athlete, children or adolescents are exposed to that, usually are the one who are often involved in more talented program and exposed to high and repetitive stress. And based on the sport, again, based on the sport, it could be more the elbow, or more the wrist, or more the knee, more the ankle, so or more the hip. So the sport specialties play an important role on the occurrence of this type of injuries. And then a third type of injuries involving the growth plate are the apophyseal type of injuries, which result as well from a high and repetitive stress over a time. And they can occur in two different ways. They can be insidious and come step by step, I will say, but also they can be acute, but the acute onset is just the top up on a previous chronic and repetitive stress that make weaker the apophysis, and then it is just need to have a little bit of power, power shoot for a football player, and then the apophysis is not resilient, strong enough to cope with this shearing stress, and then we are facing, let's say, the apophyseal injury. And if in this type of injuries as well, if the stress is very high with apophyseal injuries, it can end up by an avulsion fracture.
Yeah. There is so much variable here. And yet, so
And
it's not just.
it's very important to dissociate all of this type, because it's so important, because then only by a good recognition you can implement timely the proper management and proper rehabilitation process.
Yeah, exactly. And yeah, so it's not just underdeveloped tissues, but also movement patterns, proprioception, and even hormonal factors are here. And we often focus so much technique or tactics at that age, while ignoring how unprepared their bodies might be for repeated load. Now, when you combine that with year-round training or early specialization, things can get risky very quickly. And we see a rise in early specialization and year-round training in youth sports. And this raises some questions. For example, do you believe early specialization and high volume training environment compromise tissue adaptation in young footballers? And how do you navigate this with coaches and support?
So if it depends of what your early specialization is well known, but if we see early specialization only through the musculoskeletal perspective and not, let's say, to the coordination, if we look only at the tissue, because the early specialization has an impact on the mental development, on the coordination development, on the musculoskeletal development. So there are different part of the body, part of the human that is developed through early specialization. If we look only at the musculoskeletal aspect and the growth plate, in this case, of course, early specialization is going to be an approach that got to put the athlete, doesn't matter sport, at high risk of growth plate injuries. Why? Because when you do early specialization, you go straight away to an early repetition of similar movement, which got to put a lot of stress on always on the same area, on the same zone.
Yeah.
And then some athletes it's like a muscle injury. So it's like um, some athletes are more cooper or less cooper with the load. And I have some players who go through the full development on of an early specialization program of football from 10 years old to 19 years old without suffering from any gross plate injuries. And I had some players who did the similar program, even in the same age group, and from the same generation. So they were training, the training was the same. They had the same coach in the same time. And players who every year they were suffering from different type of gross injuries, like apophyseal injuries. And basically, he starts from the heel when they were younger, and then he moved to the patella, then moved to the knee, to find tibial tuberosity, then moved to the pelvic, and even sometimes can end up also by the pubic. So we also need to understand that there are some young athletes, doesn't matter the age, who can the structure, their body, and their genetic or biological constitution make them able to cope to such program. And then you have other athletes, even you do the best early specialization, let's say development program and load management, there are some athletes where their body, their genetic will not cope to such a program. So this is, I think, something very important to understand. Now, to come back again in terms of tissue adaptation, I think, because I've been working in different environments, some environment applying an early specialization, and some environment not applying an early specialization, but applying an early diversification. But you also expose the players in terms of growth plate. I mean, in early diversification, you are also exposing the players to some different type of stress where the body may not be adapt. Because an early diversification, I think it's also important to plan because if you change often the variety of input, the body may have not the time to adapt. The tissue of the body may have not time to adapt to this type of new type of sport diversification. And then you change to another one, and then again another type of stress, and then the body has no time to adapt. And then maybe on the end, you can also have some players who are starting some symptoms in some growth plate. So growth plate is a very specific tissue. And I always say to the team working with young athletes, is the most important for me is to understand, to flag if we are facing an athlete who will cope with his growth plate or he will not cope or struggle to this type of injuries. And I'm talking more or less for everything related to overload, overuse type of injuries for the growth plate. So the primary peripheral injuries and apophyseal injuries. So now to come back on the tissue, in the early specialization, I think when you do a good early specialization, I think you and you are well aware about the sequence and the chronology of the maturation process and the ossification process of the apophyseal injuries, which often is the apophyseal injuries, at least in most of the sport, are the most frequent. I think you can, and you manage quite well. And if you flag well the player who are more at risk for this type of injuries, and you understand what is their risk, because I will come back on this one later, I think you can navigate and a little bit by an anticipation, by a proactive management, you can, let's say, drop a little bit the risk of this type of injuries by always be in front of the maturation process and prepare the body for that.
Yeah. Okay. Wow. These are such critical insights, especially in high pressure systems where they are pushing kids as if they were small adults. It is really important to advocate for tissue tolerance and small progression, which actually brings me to something we all struggle with, pain in this population. When is it just growing pains, and when should we worry? Because we often hear that growing pains are just part of the being an active kid. But where do you draw the clinical line? In your clinical opinion, when should such pain be considered a red flag rather than a normal part of development?
Yeah. So just before, because I take my notes here, and just before, because you mentioned the tissue tolerance, and the tissue tolerance is just to finish in the previous question. The tissue tolerance, it's something very important to develop youth athletes, and often the management of gross plate injuries related to the stress and overall use, we remove the player and we stop the player from the activity. By doing that, we are not helping the tissue tolerance. We are even making a little bit more fragile the tissue tolerance. Of course, if we are in a situation, and that's why education is so important for the parents, for the coaching staff, because the education will be, proper education will be a huge tool to support the tissue tolerance. Because some parents sometimes, they're excited that their son or their daughter are playing in one club, and they want the player to do the best and push and push. And we have also the coach who wants them to get some result, and different academies work in different methodology. And by understanding everything, um, and understanding the concept of tissue tolerance, the way you expose the players. So if the player declare the symptoms very early, very soon, then a gross plate physical stress, hypophyseal stress injuries can be much more easier to manage, because we can drop a little bit the load based on which apophysis is
Okay.
symptomatic,
Yeah.
and then drop a little bit the load and see how the response of this apophysis, how the apophysis responds in terms of symptom. If the symptom drop, then maybe you find the right drop of load, and then the player can continue his development while without stopping totally the player from the activity. Because when if you stop totally the player from the activity for an apophysis, you need to again to reload the players and go through all process and again find a tissue adaptation, and the resilience of the apophysis was been symptomatic, and then it may take some time. And then in the meantime, by the time of the length of the recovery process of this previous apophysis, maybe another apophysis go through the ossification process, the orthogonal ossification. And maybe when you reload the players, if you reload him too quick, or you focus only on one, then maybe when you return to train from the previous one, then maybe the other one start to pop up. This is something really to always to keep in mind, because all apophysis, all gross cartilage are there during the entire life of a development of a youth athlete. And when you, let's say, when you are leaving the risk of one gross plate area, let's say the tibial tuberosity, naturally the body is more exposed, maybe at some pelvic area, because it's a processus of the
Yeah.
growth and maturation. And in the meantime, the growth and maturation, the body has grow, get more mature. When you play in team sport, all your mates also have grown. They didn't stop to play football. It means they've developed as well as a team. So when you return back a player in such environment, he should be stronger and faster than he was before to get injured. To stop the players, his
Yeah.
teammates continue to develop in the squad
Oh, yeah.
as
Obviously,
as
yeah.
agile bodies, as a team, and then
Yeah.
he's coming back in a stronger and more powerful environment that he was when he got injured. So the physiotherapist must understand that
Uh-huh.
this is part of, again, tissue tolerance, because we are in a youth development, and that's why I always say to my team that dealing with young athletes is much more challenging than dealing with adult player, because a professional player, you have to bring him back to
Uh-huh.
his former level of performance, because he's done, he got his level, and then he's just maintaining and performing, and you need to bring him back at this performing at the highest level that he can. But a youth player, you have to bring him back stronger than he was before, because the growth and maturation process of the team, the squad, has go through, and is coming a brand new environment compared at the time when he left.
Dear doctor, I'm very impressed because these are very amazing experience, and we are thank you sharing their with us. And maybe we think load management right now because one of the most challenging parts for clinicians is load management, especially as you said when the athlete's still growing. And what is the typical recovery timeline for a graft plate injury? And how do you manage expectations with players, with parents, and with coaches, especially when growth is still ongoing?
Yes. So the of course the timeline is based on the severity of the type of injury, the severity, and the area. Like I said, there are three big type of injuries: all physical fracture, like salteraris, where based on the type of salteraris, some of them are quite don't require time loss or a minimum of time loss, but an appropriate monitoring. Some others are very severe and require surgery. So it's the same in the primary periphyseal stress injuries regarding the epiphysis, the metaphysis, and the physis. Some of them, so that one are the one due to stress and overuse, involving the growth plate at the extremities of the long bone. This means the weight-bearing growth plate, and this we know in sport. Some bone are more exposed in sport than others. And for example, also even in a bone, like the tibial bone, the proximal tibial growth plate in football player is more exposed as such primary periphyseal stress injuries due to the compression, due to the sport, than the distal growth plate of the tibial bone. So there is really some specificities due by the sport. So, and again, based on the severity of these primary peripheral stress injuries, if they are timely well diagnosed and well managed, usually there is no there is no bad consequence for the young athlete. But if they are not well diagnosed on time or badly managed, then some of them also can end up by a surgery. And again, consequence of this type of injuries, doesn't matter if it was a physical acute stress like a salteraris or an overuse one. When you are talking about fracture, poorly managed, one of the potential consequence is that you have an early ossification of this growth plate, and then this growth plate doesn't go through the full process of the endochondral ossification. And then you may end up, for example, maybe with a leg a little bit shorter if you are talking about the proximal tibial growth plate, or because the growth maturation process has been stopped, arrest. Yes. So this is one of the risks
Yeah.
of when
Okay.
we are facing severe type of injuries and they are not well managed. But if everything is well managed on time, usually uh, there is no, let's say, consequence in the long term when the athlete is adult.
Okay. That leads us to tricky clinical question. Actually, how do we progress loading these cases? Because maybe many physiotherapists are hesitant to load young athletes. And what's your perspective on load progression during or after recovery from a growth plate injury?
So again, it's based on the type of injury.
Yeah.
And this is an important point, because if we talk about the fracture, the acute stress fracture, this is a different category. Usually, most of them usually are contact injuries in contact sport. But if you are talking about the overuse one, we need to understand what has been the cause of the stress. Because, like I say, if it's the proximal tibial physis, we know that the factor has been a compression. We may not have the similar cause beyond this similar type of injuries if it's the concern of the distal tibial physis. So the medical team must really understand the cause, because, and if you are talking also about apophyseal injuries, the cause will help you. The understanding of the cause will help you to guide and to navigate through your rehabilitation process and making the return to training, return to play process in more optimal way. Because if you're talking apophyseal injuries from the knee, okay, and if the player has come to you directly, he felt the first time the symptoms, and you try to drop the load, even doesn't cope, so you need to end up by stopping the players. So then we have the clinical assessment, of course, to understand when you can reload him. But then, as you know, that dropping the load progressively didn't help to find a certain low threshold that the player can cope. So in the end, your progression, and often in this case, the progression of the rehabilitation must be really progressive. And then you have some players where you can see that if he has been, for example, for a long time playing with the symptoms and come to you after a while because he cannot anymore because he didn't tell you, you need to stop him because he's too symptomatic. You may face a profile of player where quickly the symptoms will disappear. And based on the clinical examination, you will find out also by your follow-up that you can reload the players a little bit faster at some stage to return to train, but maybe keeping him not again at the full level of training volume over 1 week. And maybe, I don't know, maybe two sessions instead of 3, or 3 instead of 4. So there are so many ways to play with the reloading process of a player, because in this type of apophyseal injuries, we need to understand that there are two things that a physiotherapist need to monitor and to understand how to reload a player is the peak threshold. So is because an apophysis is always linked to a muscle group. If we talk about the apophysitis regarding to the quadriceps and patellar tendon, and for Sending Larson, if we talk about some apophysis from the hip. It could be related to the hamstring by the ischial tuberosity. It could be related to the rectus femoris relating the anteroinferior iliac spine. So every apophysis, the physiotherapist must understand that the peak threshold and the capacity threshold is the way I manage the rehabilitation. Peak threshold is the capacity for the player, the athlete, to do one repetition, let's say full power, without having pain to his tibial tuberosity. While before he was doing one shot and he was feeling pain. So then you bring back the player, he got the peak threshold, he's able to cope to one full power activity. But then the physiotherapist must understand that this is not enough in high level development, and we need also to restore the capacity of this apophysis to cope with the stress. The capacity again to repeat the stress. And that's why in the rehabilitation process, to tissue adaptation, to don't lose tissue adaptation, and to rebuild tissue tolerance based on which apophysis has been injured, and the stress has been the cause of the problem. You can maybe progress quite well in many other stress, but maybe for this specific stress, you need to have some time to regain again the capacity of the apophysis to cope with the load. But doesn't mean that he's not able anymore to cope to a normal football session. Play football because it's pain-free. He will cope to the training. But when you do weak footwork, because maybe it has been the cause of the symptoms from the left oscillator, a high load, high volume of weak foot shooting exercise. So keep him away of this type of exercise at the moment. Give more time to get back more capacity of this apophysis to cope again with the normal football stress without specific input on the tibial tuberosity. Because at some point, it's important, yes, he has been injured in this area, left oscillator, but at some point, sometimes when you reach a certain level of return to training, return to play, you don't forget, but it's good to don't be anymore too focused on that and to look more at the whole body, and the skeleton must again go back to avoid other subsequent apophyseal injuries. Because we start to know a little bit also by the science and by the research that a player who got a severe disease at the heel will be 5 to 6 times more at risk to get an oscillator 2-3 years later when he will reach this maturation time frame. And I think there is no research showing that, but with my experience and with some data, I can say also that the risk is the same. Players who got severe disease or oscillator will be more at risk to get an apophyseal injuries around the pelvic at late adolescence. And that's why it's important to flag early the gross plate injuries in soon the young athlete is with you in your sport. Like that, he got already this one at that age, he got this one already at that age. So we have to anticipate maybe he's at risk to get the next one when he will be late adolescent. And we need to have this proactive reasoning.
Yeah, that is such an complex and important point, and honestly, something many of us still hesitate about. And I am now seeing how a well-structured learning plan can actually support tissue remodeling, especially when progression is individualized and monitored closely. And it's a reminder that avoiding load altogether might do more harm than good in the long run. And speaking of the long run, I'm curious about return to performance after such injuries. Based on your experience, the young athletes typically regain their full performance capacity after a growth plate injury, or do lingering deficits tend to persist?
So usually, yes, most of the time they regain the full capacity. And again, it's always the age also play an important role because it's not regaining the full capacity the problem, but it's not losing a long period of development and exposure at some critical age. So it's more the impact to suffer from recurrent different type of growth-related injuries, because this is the topic of our podcast, who may create a lot of layoff from the development. And then when you got a lot of layoff in your development at some critical age, like 17, 18, 19 years old, then it's a key moment, to step up from late adolescent, at least in football, because in some sport, the key moments are a little bit earlier. And here even I'm talking about boys, but also the key period for young female adolescent is also different. So sport specific and gender specific, the key development in terms of development process. But is the layoff, the consequence of the layoff will impact the time, the loss of development, and then maybe some players may not catch up what they have lost. But with my experience, what I said earlier, normally, usually they don't impact. No, for me, regarding a critical apophyseal injury is the iliac crest. Because there are two types of iliac crest apophyseal injury. You can have an acute onset, involving an avulsion of the iliac crest. And based on the maturation level of the iliac crest, the avulsion may be bigger or smaller because the maturation process of the iliac crest follow the riser maturation indicator. And then usually when iliac crest apophyseal injuries is not timely diagnosed and well managed directly, you may end up with recurrent symptoms. And the fact that the iliac crest, because a tibial tuberosity is an oscillator, I don't want to say, sometimes we have some bad oscillator difficult to manage, but we are mainly in one plan, flexion extension of the knee. But the iliac crest, we are in the three plans of the human body. Because on the iliac crest, we have 7, 8 muscles inserted on this upper extremity of the pelvic. So when the player will do hip flexion, the psoas will put some stress, some shear inside of the iliac crest by the inside of the pelvic. When you do some abduction, the abductor muscle will put some stress there. When you do some knee extension, or hip flexion, the sartorius and tarsal fascia lata and rectus femoris will put also some stress. When you do some abdominal work, they will put some stress. So the iliac crest apophyseal will get shear in everywhere by all of these muscles. So it's very important to flag because the muscles don't insert, all of them don't insert in the same spot. So for the clinician, it's very important to understand which spot is the more symptomatic. By the muscle testing, you can find out. Um, and then the way to manage this type of stress injuries, it's a key because if it's not timely diagnosed and well managed, the high is really an hypophysis at risk to have a lot of long-term symptoms where the player near the late adolescent moment, which is a critical age for the players. And if you end up with chronic symptom where the player is not able to come back at his performance level in a relative short midterm, then he start maybe to miss too much and then miss, let's say, the opportunity to do the last step to progress to elite level. So this is more the risk that we may face. But again, early diagnosis, early time results, and monitoring is the key. And also education for the parents and the kids to understand that. And usually me with the Liacres, I'm quite very conservative and to switch off as soon as possible the all shearing, even during a time, but really to switch off. And is maybe the hypophysis where I'm very conservative. While with other hypophysis, I'm happy to try to deload, find a way. Iliac rest based on the symptoms, I'm quite conservative.
Okay. I think we sometimes forget the psychological and neuromuscular integration these athletes need, maybe, and that's why I want to ask you about the broader impact on musculoskeletal development. And it's my last question, also. And how the growth plate injuries, um, because no, I'm actually saying that. It's not just about the injury itself, but how it alters mechanics, symmetry, and tissue response over time. So it really calls for a strategic monitoring plan, and especially when the rehab approach can vary based on the type of plate injury. So not all grave plate injuries have the same clinical presentation, and I would love to hear your thoughts on clinical reasoning here. And do epiphyseal and apophyseal plate injuries require you to adapt your rehabilitation approach in immature footballers? And if so, how do you adapt your rehab management for it?
So again, understanding the peak threshold and the capacity when the player complains for the first time from here we are talking about the stress injuries, the overload one. So understand the peak threshold and the capacity. This is the key to see where the athlete is. And of course, when it's then you need to understand the full clinical picture about the pain level. Usually, we accept always a pain threshold on the VAS scale to say, okay, if it's less than 3, for 3 or less, if the player is fine to play, fine. Now, with some apophyseal injuries, you may have some compensation. So when there is some compensation, I think there is no point to try to bring back the player to try to have a load management. You need to solve a certain level of symptoms to again avoid all of this compensation. But I think also it's important to understand the environment of the player. So if we are at the start of the season, or if we are at the end of the season, because some players may have the symptoms at the start of the season because the development program has been too quick to increase the load, and the player, the skeleton of the player didn't like it. And maybe other player, they cope to that, but by the end of the season, because the athlete has been so much used by the coach, trained, didn't miss any training over the season, then his skeleton starts to struggle a little bit with the full season. So we need to understand the moment where we are
Okay.
and the cause. So because if it's just a quick, um, a too quick increase of the volume of the load of the program, so it's also one way to different way after to reload the players. Also, we need to understand if some sport, for example, football, it may occur because you play a tournament and you have 10 games, 10 small games over the course of 1 week, 10 days. So it's a good, it's an important congestion of games that the player, his body is not used, but after maybe 2-3 days after the tournament, all symptoms settle and fine. So we need to understand that. For example, in football, goalkeeper player, the training type of goalkeeper player is very different than the outfield players because it's very specific of jumping and diving. And usually, for example, something that is people in club often manage goalkeeper as outfield player, let's say for a similar type of opposite injury, so shatter. While a goalkeeper, the training is much more demanding than a game in terms of musculoskeletal stress. So rather to stop the player from everything, maybe dropping the goalkeeper player as a goalkeeper training volume, but keeping play as a goalkeeper during the weekend because he's young, he still need to develop, and for his mental health is good because we keep the activity of football in his brain. So we keep also working on all of these different input. And the reasoning must always, for the practitioner, be aware about all of this. The player, the symptom and the diagnosis, the context, how the pathology occur, find out what has been the overload, the causal issue behind, and then the context of the team, of the squad, from today, tomorrow, and the future, to see how I'm gonna to bring back the player or try to make the player lose as less as possible the development program. And then after you can also play with the position. So and you need to know the physiotherapist must consider all of these contextual factors to have then the most appropriate clinical reasoning for the players based on the symptoms and to progress the player. And that's why it's so specific to every single apophysis or single growth plate, sport, age, because you don't have the same age. In fact, you don't get the apophyseal injuries all at the same age. There is a chronology of the maturation process. So that's why it's very complex. And I never managed twice in my career. I've never managed twice in the same way a growth plate injuries. It has been always idealized to the player. But it's look complex, it's look difficult, but I think and I will say for the young clinician, I think it's what is, I think this type of challenge, I think might make you motivate and happy to do your work as a physiotherapist. Because when you are successful and you find a way and you have limited the layoff and optimize and maximize the development time, and when you succeed, then the kids and the parents give you back that for that, and then later when you see some athletes reaching a top level and you remember that you have been crossing a lot of bad time for growth plate injuries, and you see him, and I've got the case of one goalkeeper, I will not say the name, but one goalkeeper from a country, when he was a young player, he has been struggling at every age group from many apophyseal injuries. He got almost all of them. And on the end, he ended up as a goalkeeper of the lineup goalkeeper for the national team, and he played the World Cup. So it's just a proof that even you've got a long layoff, still you can make it when it's well managed and well managed.
It's exactly those nuances that I think more clinicians should feel confident navigating. Before we wrap up, I would love to hear what would you like to say younger colleagues or physio students on this topic?
But often, gross plate injuries are, because today we are still far to know rehabilitation process, because it's challenging. There is no two cases the same. That's why there is no guideline or protocol, like ACL post-surgery or hamstring injuries, because it's so much individual response. And also, in the literature, there's still not enough information regarding, even for the epidemiology. In the epidemiology, this type of injuries is well known since more than 1 century, in the late 19th, early 20th century, while the first studies in sports bring some epidemiological figures occur almost 1 century later, early 70s, late 70s, early 80s. So it has been a huge gap between the pathology and the first epidemiology report in new sport. And still today, there are still not a lot of literature about it. Football has been the sport with the highest amount of data has been reported. But if we look at the apophyseal injuries, it has been an increase of apophyseal injuries by 5 to 6 times, by 3 to 5 times, sorry, over the last 20 years. So what I will say for the young clinician is just to be, when you work in the academy, to always, it doesn't matter the type of sport, but when you are working with youth athletes, doesn't matter girls or boys, always to be aware about the different area of the growth plate. Pediatric sport medicine practitioner and not an adult. So for me, it's the most important, because there are so many in the past 20 years, we know by literature that so many chronic injuries chronic symptomatology has not been well diagnosed, because never the growth plate has been considered as the tissue beyond the symptoms. So when you're working with immature skeleton, always consider as the first that you may face a growth plate issue. And prior to do the opposite of reasoning, or maybe it's a muscle, maybe it's a tendon. No, for me, when I work with my physio, my team always say to them, first, differential diagnosis of a growth plate when you are on a spot of a growth plate. And after, we can go deeper and go to the right diagnosis, but exclude as soon as possible the growth plate.
Okay. That was such a thought-provoking conversation, and huge thanks to Dr. Olivier Materne for sharing his clinical
Oh, thank you.
experience and deep understanding of youth sports injuries. I hope today's episode gave you some new angles to think about, especially if you ever hesitate to load young athletes or wondered when growing pains become something more serious. As always, if you enjoyed this episode of PhysioPod Plus, share it with a colleague or coach who works with young players. Thanks for listening, and I will catch up next time on PhysioPod Plus. And goodbye.
Thank you very much for the invitation.